when I saw I had an hour, I'm one of those people who will do his best to fill that hour. Sorry. And I put together some slides. We're first going to emphasize those diagnoses from a rheumatologic nature, which you're more than likely to see in the geriatric population. We're going to try to update on some newer medications that we use to treat that population, and hopefully comment on whether or not they're any less safe, more safe than they are for younger patients. And then we'll sort of get into the controversial issue which Dr. Whiting talked about briefly, is the NSAIDs, and should we be using these drugs at all in our over 60 set. But if you have patients in your practice who have joint pain, like my practice when they're over 60, you have to do something. So hopefully we'll touch all those bases before we wrap it up and leave time for questions. Although I know there weren't questions on the last hour, but nonetheless, here we go. So rheumatologic considerations in the geriatric patient. Now that I am a geriatric patient myself, I guess that has even more meaning for me, this topic, but there's where I currently work. As Carol said, I graduated from the institution in '75. I'm back there now 21 years in various capacities and still seeing rheumatology patients despite administration and teaching. I like the mix. It sort of breaks things up. There's a picture of our campus. Let me see if I can. Can sort of see it. And in past, we had a chairman of the board who wanted to please the students. They built a beautiful student activity center on the left there. And don't hold this against me or don't laugh too loudly, but that's where the 76ers practice. I know what you're thinking. I think we won 15 games this year. What do you want, 17 maybe? They need more practice, I think, but they built them a beautiful facility on campus. A lot different than the campus I was studying on in 1975, I'll tell you that much. So there's our campus. So case number one. And to try to keep me awake, or you awake, we'll sort of do a case-based format. And I'm cheating here because I'm not showing you bilateral hands. I'm only showing you the left hand. But you get a feel for some swelling. No auxiliary. This one doesn't work so well. But so you see the, sorry. Oh, you can? I'll try that. Oh yeah, thank you, Carol. You see some swelling at the PIPs. See some swelling at the MCPs. One of my favorite little tricks for the students and residents on service are, if you're not sure if somebody has any MCP swelling, sort of come out and put that slide in, but sort of make a fist yourself, and you'll see that their joints are a lot less distinct than your own. But this should really be bilateral, symmetrical. We didn't know what he had initially, so 2 weeks later we brought the patient back, and no, doesn't progress that fast, actually. I'm glad, I'm just testing you, make sure you're still with me. It doesn't quite go along that fast, and you might say, well, I see classical ulnar drift on the left hand there, or the right hand make that, but the left hand looks pretty darn good. Well, if you look closely, you'll see a nice well-healed scar there where the local hand surgeon did his or her thing and fixed their left hand. Many of us rheumatologists are conservative with referring patients to hand surgery. Hopefully there are no hand surgeons in the room who will throw something at me, but there is one. No. But we like a hand that functions, and sometimes a hand like this can become much more pleasing to the eye, but it may not function as well as the hand to the right. And always remember, I'm not a rehab doc, but remember that this little function right here is about 80% of the hand's function. So if they can do that, button buttons, do toilet things, do some avocations that they enjoy, females do their knitting, men knit too, but then we don't send them off to a hand surgeon, sorry. If their hand is functional, we let it be. Sometimes you have to convince them, but you know what? I have to be honest. With these newer medicines, which we're going to talk about, we're not seeing this anymore. One of those medicines, if you watch golf like I tend to do, Phil Mickelson takes one of those fantastic drugs. We'll talk about that momentarily. So no doubt as to the diagnosis of rheumatoid arthritis. And if I were sitting on your side, I'd say, come on, Pascucci, rheumatoid arthritis is 20 to 40, 45 years of age. It's a young person's disease. Females, 3 out of 4. And I say, yep, But as we live longer, whatever that cause is, and it's used, we think it's a virus. You know, we're physicians. Whatever we don't know has to be a virus. So we think it's a virus, and the virus that causes it can affect people over the age of 65, I hate to tell you. And it used to be a sad story just even 15, 20 years ago. They work hard their whole life, the male or female. They're 65, 66 years of age, retired. They want to enjoy life, and they develop rheumatoid arthritis. But I'm going to say it for a second time. It's a whole new ball game out there. It is very different, the management of RA. And you look at this great slide that I borrowed from Dr. Warren Katz, an excellent clinician from Philadelphia originally. I think he may have retired. But elderly onset is one of the 9 different presentations of rheumatoid arthritis. Sort of insulting to me, that word elderly onset. I like, now that I've sort of reached a certain number in my life, I think it should be called maturity onset rheumatoid arthritis, not elderly onset, you know. So what are the characteristics of your 60, 65-year-old patient? We'll give you a quick case that happened. Always like my cases. Just recently. Onset after age 60. There's where I get a little nervous when they call that elderly. Where did the new 40, 45? What are you talking about, you know? Acute onset is common. Their symptoms may present to you overnight. Doc, I was fine 2 days ago, woke up, stiff as a board, shoulders hurt, hips hurt, couldn't move. The female to male ratio is not quite that 3 to 1, might be 2 to 1, might be pretty even. An increased incidence of systemic symptoms, so they'll have high fever. They can become acutely ill. You're not sure what's going on initially. And a predilection for large joints, I just told you, shoulders, hips. So you have a patient calls your practice, stiff in the shoulders, stiff in the hips. Happened overnight. Their wife had to help them or their husband had to help them roll over and get out of bed. As a rheumatologist, you question about the flu. Of course, they usually get to see our primary care docs first, those in the trenches. But if it gets to our office, we say, they give you that history, and I'll say, polymyalgia rheumatica. And we're going to go over and over this again in the next 50 minutes or so. Sometimes a difficult differential diagnosis between maturity onset rheumatoid arthritis, elderly onset, and polymyalgia rheumatica. They have a lot of similarities. So the hips and shoulders. So EORA, elderly onset RA compared to young onset RA. Shoulder and hip synovitis, acute onset, PMR-like presentation. You'll see this over and over. Elevated SED rate, highly elevated. Decreased incidence of small joint disease, extra-articular disease, nodules, and seropositivity. Here's our criteria for rheumatoid arthritis, and they still hold up in the geriatric population. And they're from the College of Rheumatology, 1987. There are new criteria out from 2010 from EULAR, the European League Against Rheumatism, and the College of Rheumatology. Say, well, why didn't you put those in? Let me tell you. They're 3 pages, a lot more complicated. I still like the KISS principle when it comes to coaching sports, don't do that anymore, and teaching medicine, keep it simple. And the criteria: morning stiffness, swelling of 3 joint areas, swelling in the classical distribution, wrist, MCP, PIP, symmetrical joint swelling, hand x-ray changes, sub-Q nodules, and positive rheumatoid factor. Now remembering again that your geriatric population may not have positive rheumatoid factors commonly, and they may not have the small joints, even though rheumatoid arthritis, defined for us as an inflammatory polyarthritis of unknown etiology, it's rheumatology, where the predilection for the small joints of the hands and feet. That's how young people present, or elderly present a little differently. Differential diagnosis, other connective tissue diseases, we'll get into some of those, lupus, etc. SBE, hypertrophic osteoarthropathy, which can be a paraneoplastic syndrome for cancer of the lung or other large tumors. But had a great case when I was over in Lansing of a local golf pro, 42 years of age, came in the Lansing General's ER, sick, but afebrile with an infiltrate in his chest. He had about 100 pack years smoking at age 42. He was being treated by a chelator for arthritis, rheumatoid, and that wasn't rheumatoid arthritis of his joints, it was clubbing, and he had hypertrophic osteoarthropathy. He didn't live too long, unfortunately. I didn't put the slide in on clubbing, but you can see where tophaceous gout could confuse us, and there we have it again. polymyalgia rheumatica in the elderly and even rheumatic fever in a younger population. Overlap again, polymyalgia rheumatica and elderly onset rheumatoid arthritis. A relatively new antibody. It's been available to us commercially about 4 to 5 years now. Can be helpful. The anti-cyclic citrullonated peptide, anti-CCP, sounds like a Russian hockey team, or their sweater at least that they wear, you know. Your Red Wings did like my Flyers this year, not so well. Of course, the other Pennsylvania team went out last night. The Pittsburgh Penguins lost to those Rangers. But anyway, this is relatively new, and early on it wasn't quite as sensitive. They're getting there as the rheumatoid factor, but it is more specific. If that's there, you're pretty convinced it's RA. The case I had recently was one of our former professors. He's 80 years of age. His son's on our faculty. His son calls, "Dad, need you to call him. He's in Florida. He's sick." Okay, call your dad, but you're a family doctor. Did he talk? Yeah, I spoke to him, but he wants to talk to you because it has to do with his joints. His shoulders are killing him. Okay. He gives a presentation to Dad over the phone, 80 years of age now, male. All the world sounds like polymyalgia rheumatica. I said, well, you're 1,200 miles away, so when you get home I have to see you, but you really sound like polymyalgia rheumatica. And I told his son what test to get done. SED rate modestly elevated, not horrible, but modestly elevated. I said, intriguing. I told the son he either has polymyalgia rheumatica or he has what we call elderly onset rheumatoid arthritis. So I gave him the treatment of polymyalgia rheumatica. Bad, over the phone, but he's hurting. He's in Florida. He wants to play golf, you know. 15 milligrams of prednisone. I said, you're calling me in 4 days. Tell me how you feel. He said, I feel great. So you say, oh, good, I nailed the I have the right diagnosis. He says, except my left shoulder. I said, so much for the right diagnosis. I said, I think he's got rheumatoid arthritis. So about 2 weeks later, he comes into the office, talk to him. Old rule of thumb in medicine. Sometimes it pays to examine the patient, not just treat them over the phone, you know. So we get to his hands. I said, his son is with us, the family doc. I said to his son, can't help but quiz, you know. I used to quiz Canfield in the old days. Said, what do you think of these hands? He says, Dad has synovitis. I said, well stated. Your dad has elderly onset rheumatoid arthritis. And sometimes the treatment is steroids. If they're 80 years of age, we used to say this. They're 80 years of age, what? They're going to live 3 years, 5 years, 7 years max? Those bets are off now. People are living a long time in this country. Matter of fact, I was reviewing some of the optimum aging notes. 13% of our population over 65, and the number keeps going up, right? By 2050, it'll hit. So, but if you can get the prednisone down to 5 milligrams, we rheumatologists tell you, minimizing side effects at 5 milligrams or less a day. I still don't like that drug long term. We've all seen the nasty side effects of steroids, but it was a first-line treatment in case it was PMR, and if I have to, I'll get him on methotrexate, but we're jumping ahead. So, interesting case, again, emphasizing the difficult differential diagnosis between elderly onset rheumatoid arthritis and polymyalgia rheumatica. All right, so the CCP can mark a rows of disease for you. I like it with rheumatologists. We like this hedge term. You'll send us a case. We're not sure if it's early lupus or it's early RA, and we call it undifferentiated connective tissue disease. Sounds so much better to tell the patient that they have undifferentiated connective tissue disease than, what's wrong with me, doctor? I don't know. You came 50 miles to see me. You're paying a big consult fee, and I don't know what's wrong. So we say, you have undifferentiated connective tissue disease. Doesn't that sound great? And we know that in time, it's going to go either to lupus or to rheumatoid arthritis. So, and in time it'll show it's, but if this CCP is elevated and you're still not sure if they have lupus or early RA, you can bet it's rheumatoid arthritis. And another term that used to make rheumatologists nervous, seronegative RA. Even though the sensitivity of the rheumatoid factor in young people is only 80–85%, if we're convinced it's rheumatoid arthritis and they're seronegative, it makes us nervous. We probe for psoriatic arthritis, for Crohn's or ulcerative colitis with arthropathy. We probe for reactive arthritis. Are they not telling me the truth about, you know, have they had a little something going on the side? So we look and look and look for other causes other than rheumatoid arthritis, even though the books will tell you 15% or so are negative. And if You'll find an occasional who's seronegative, rheumatoid factor negative, CCP positive. You know the diagnosis. It's rheumatoid arthritis. Pretty darn sure. You can put an X through this one, although it's a beautiful slide of the pyramid approach to treatment. Out the window, gone. That's the old way we used to approach. But we have learned that the most significant damage to the joints of RA occur in the initial 1 or 2 years of disease. There's another good thing about this elderly onset RA, the acute onset. It tends to leave the patient as quickly as it came, like in 2 years or so. Not 100%, nothing's 100% in medicine. Never say never, never say always, but it tends to, and what does that sound like again? Polymyalgia rheumatica. You know, our British brethren, they talk real nice and they write some beautiful editorials. I'll never forget the editorial in Journal of Rheumatology, done some 20 years ago, because I was lamenting treating this gentleman for polymyalgia rheumatica for 6 months, and finally he walked into the office and went, "Hey, look, doc, look at my hands." I said, "Oh man, I missed that diagnosis by a mile," beating myself up. Then you read this editorial and it says, elderly onset RA and polymyalgia rheumatica are basically a spectrum of disease. If they're on this side of the spectrum, they have synovitis and look like RA. If they're on this side of the spectrum and their shoulders and hips hurt, it's probably polymyalgia rheumatica, but they're one disease that has a whole spectrum of presentation and activity. And I've held on to that. It helps me get to sleep at night when I kick myself for missing another diagnosis, you know. But rheumatoid arthritis, treat aggressively early because the damage occurs early. And we've learned that over the years. I like this fancy slide. I'm assuming all these slides will be available for the audience to download and look at. I like this one. And you know, still our basic treatment is NSAIDs. We're going to talk about those. And I'll pick it up here. Cornerstone of management, call it the DMARD of choice. Disease-modifying anti-rheumatic drug of choice for RA is methotrexate. When a patient walks in the room and you make the diagnosis of RA, I can feel the methotrexate flowing. I used to be conservative and try a couple NSAIDs. They get methotrexate. The same time, I'm sending them to the lab to draw hepatitis B profiles and hepatitis C profiles. Because of the potential liver damage from methotrexate, it's a relative, if not absolute, contraindication if they have hep B or hep C to give them methotrexate. It may make their liver disease florid. And if Detroit is anything like Philadelphia, any large city, about 3 to 4% of our population in Philadelphia has hepatitis C, and the great majority don't even know it. So in urban areas, we're seeing a lot of hep C, so we test them. It's our standard of care. Test before you use methotrexate. If that fails, most of us are now going to, actually, we just give them methotrexate and TNF-alpha inhibitor. I mean, some of the insurances in Philly, I'm sure, same in Michigan, they want you to give 2 DMARDs before they'll approve TNF-alpha inhibitors. So we use methotrexate plus azolfidine, sulfasalazine. And then there was a nice article by Odell in the New England Journal of Medicine about 1998 where he gave hydroxychloroquine or Plaquenil plus methotrexate plus azolfidine, sulfasalazine, and said the patients did better than on any drug alone, and he saw no increased toxicity. So it depends on the insurance, but most of us are adding a TNF-alpha inhibitor if a rapid increase in dose, get a good response to methotrexate. And that's what we're doing. If that fails, we have choices like abatacept, call it Orencia. Nobody's sponsoring these, so I can't even say brand names, right? Rituximab or Rituxan, which has found its niche in treating lymphomas and leukemias. We rheumatologists are amateur oncologists. We just are chickens. We use low doses where they use high doses. So Rituxan we barred from them as well. And Gold and Arava are really out the window, penicillamine, unless the patient is hep C and can't tolerate other meds, and you have to do it. And we're not done yet. So there are others we have out there. There are other biologics or TNF-alpha inhibitors, newer ones, Cimzia and Simponi. And then if that doesn't work, you have another option. And what we do basically is, if you get to TNF-alpha, etanercept or Enbrel is the most widely used by rheumatologists in this country. And again, I'm not sponsored by anybody, just telling you the truth. They have about 65% of that market. Humira, adalimumab, is a second. So if my patient, and Remicade gets their share as well, which is the IV, infliximab. If they fail etanercept or the first TNF you give, it's warranted, and this is our standard of care, is to give a second TNF, not together, no two biologics together. So you stop the one, try another one. If they fail that, then you're going to either this Actemra, which is an interleukin-6 inhibitor, or I've used Orencia, fair degree, and had good success. I've not used much Rituxan, but also very effective. Rituxan, though, has some funky side effects, which can be tough. So, but this is another possibility. And then there's now, for those, and it's funny, my urban population I treat in Philadelphia. Doctor, I don't want any needles. I said, I don't want you to come in here suffering with rheumatoid arthritis. Methotrexate isn't working. Azolfidine isn't working. You have to take a shot once a week. I can plug you in an IV every 8 weeks for 2 hours. An IV? Now there's a new drug on the horizon, relatively new. It's been with us for about 2 years. Xeljanz, tofacitinib. Isn't it easier to say Xeljanz? And it inhibits Janus kinase, another inflammatory mediator, a different little pathway, and it's 5 milligrams orally BID. By the way, are any of you cost-containing in your practice of medicine? People laugh at me, but I am. My TNF-alpha inhibitor is about $30,000 a year, if not more. No offense to the company, but that's one of the reasons I don't use as much Humira. Humira is an every other week dosage. Patients say, isn't that great? I only take the shot every other week. What do they recommend you do as a clinician if they don't respond to every other week? Oh, give it once a week. My $30,000 a year drug just became $60,000 a year. So I have a little problem with that. This drug, which is oral, and these drugs are all about $30, $35 a year. This drug that's oral, twice a day, $30,000 a year. A lot of money for the cost of taking care, but if I can keep a patient working, and it's not just today's topics, early onset RA, but if you're rheumatoids, you keep them working in the workforce, keep them healthy, then it's saving money. Systemic steroids, yeah, they have advantages. They really can control symptoms, but just too many side effects to be used long term. And how's the prognosis? Shorter duration of the disease, like I said, it usually goes away in 2 years, improved joint counts, lower SED rate, and better physician assessment. So it works. Now, if I'm sitting there, I say, boy, all these poisons. We're talking geriatrics tonight. Are you going to give all these nasty meds to 65-year-olds? We have great data on methotrexate. No more toxic in the geriatric population than in the young population. We don't quite have that data in Enbrel, but we have isolated articles here and there saying that the TNF-alpha inhibitors are no more toxic than are in the elderly than are the other meds, than they are in the young. But again, our geriatric population is more prone to infections to begin with. And what's the major side effect of the TNF-alpha inhibitors? Infections. And that's why you test them for TB with a PPD or the other fancy new test for $250. I still do the PPD before you start them on a TNF-alpha inhibitor. Okay? So there's case number 1. In 20 minutes, I better pick it up. We will. A 63-year-old female presents to the office with a complaint of difficulty getting out of a chair. She has vague symptoms such as fatigue and lack of energy in association with morning stiffness and aching in the proximal portions of her arms and legs. Lab data reveals a mild anemia, normal biochemistry profile, Westergen SED rate is 75 millimeters per hour. Her physical exam is unremarkable, so no synovitis in this one. Sounds a lot like the case I presented of my former colleague who's semi-retired in Florida, came in with shoulder and hip, except when we examined him, he had synovitis. We examined this patient, no synovitis. This is polymyalgia rheumatica. And there's a lot of overlap, as you can see from that case, between the two. Older patient, normal physical exam, aching and stiffness, but some of them will develop synovitis. Again, that spectrum of the disease, elderly onset RA, and polymyalgia rheumatica. Clinical features, pain, stiffness, fatigue. They may get depressed. I heard, I got in time to hear about depression from the prior speaker. When I saw my flight was canceled, I got acutely depressed. No, but I recovered quickly. Arthritis, carpal tunnel syndrome. And I like this definition, still works. How do you die? Pain in the neck, shoulders, and pelvic girdle for at least 1 month, 6 weeks. Unfortunately, you have to differentiate acute viral syndrome. And some of these patients will tell you, Doc, I had an upper respiratory infection, sometimes we have to ask, like a week before these symptoms started, and suddenly on June the 10th, I had to get help getting out of bed. I couldn't move. They'll give you the day, the date. And it's the 50-50 club, age and SED rate better than 50, as we call it. And there's the key, as we said, we sort of had a suspicion when my former boss wasn't totally better with relief of symptoms within 4 days with as low as 10 to 15 milligrams of prednisone a day. I tell them to call me in 4 days. They should be, they think you're the best thing. I haven't felt this well. You say another steroid euphoria. I haven't felt this well in weeks, Doc. You know you have the right diagnosis. And it runs about 2 years, even though, as you'll see, some of these newer teaching slides say, well, you can get them off the med in 6 months. Yeah, good luck with that. But rheumatoid and other CTDs are in the differential. Viral myalgias, we said polymyositis, the inflammatory. Well, you said shoulder girdle, pelvic girdle. That's confusing. So one of the easiest ways to confuse medical residents on the service is to talk to them in the same breath or similarly closely about polymyalgia rheumatica and polymyositis. They both have the prefix poly. They both involve girdle muscles, shoulder girdle, pelvic girdle muscles. But one is a stiffness syndrome, polymyalgia rheumatica. The other is weakness. But they both have pain in the muscles. Polymyositis is weakness. One has the high SED rate, polymyalgia rheumatica. The other may have and it's always in that differential, a low, slightly elevated to normal SED rate, polymyositis, but they have a CK elevation, creatine kinase. And then there's that weird muscle enzyme that I think only rheumatologists order, an aldolase, probably rehab docs too, ALDOLASE, the serum aldolase. They're elevated in polymyositis markedly generally, and they're not elevated in polymyalgia rheumatica. And that helps you to differentiate in your brain between the two. One is a weakness. You say, well, you just said that patient couldn't get out of a chair, right, because she's stiff, not because she's weak. So you have to make that differentiation. And every time we see a PMR, docs always worry about, do they have an occult neoplasm, a cold infection? I've seen cases over the years sent to me after oncology had seen them, ID had seen them, couldn't come up with anything that's classical polymyalgia rheumatica. Lab, anemia, they're inflamed. SED rate greater than 50, it's the 50-50 club. Rheumatoid factor negative, ANA negative, muscle enzymes normal, it's not polymyositis. EMG normal would be abnormal in polymyositis, but don't do EMGs if you're sure of the diagnosis. Liver profile may be elevated. They may have an inflamed liver as part of their systemic illness. And remember, you're with the over 50 set, more often over 60. 30% of those patients are going to have a positive rheumatoid factor, whether or not they have rheumatoid arthritis. So you can get fooled, and it gets a little tricky with the RA factor. Are NSAIDs, is a trial of NSAIDs warranted? No. Latest literature says this, from days gone by, I would try them and then I gave up, it didn't work. Do not go with NSAIDs, they need steroids. Drug of choice, and this is from Up to Date, it says if symptom-free, 6 to 12 months may discontinue steroids, but 50% may relapse. All too often it's about a 2-year disease, polymyalgia rheumatica. So it's hard to get them totally off the steroids in 6 months. You can try. And I like to add methotrexate for steroid sparing. This is a geriatric population. They may well be diabetic. You know what steroids does to that. So we try to get them steroids, although methotrexate can bump the blood sugar a little bit too. We try to get them on steroid sparing. Prognosis is good, and it is associated with a slight increase in cardiovascular mortality. Is that the meds? Is that the steroids being atherogenic? Is it the inflammatory component to heart disease that we're hearing with rheumatoid arthritis, with lupus, with so many of the diseases we see and treat, especially RA? We have a lot of data on RA and the inflammatory component. And by the way, our TNF-alpha inhibitors finally have shown that they reduce the incidence of coronary disease in rheumatoid arthritis, any of them, because they stop the inflammation. They knock out the inflammation. So, what's that associated? Why would we do a biopsy for polymyalgia rheumatica? And why are we talking about sudden blindness 7 years after diagnosis? Was I in airports too long today? Oh, they don't walk in your office like this anymore. This was Dr. Horton's description in 1932, that men could no longer wear their hats. Frontwards or backwards, he wrote. No. And they could no longer wear their hats because they had these painful temporal arteries. Temporal arteritis is the complication of polymyalgia rheumatica in about 10% of patients. So how do you know who to send for biopsy? Everybody. No. Wrong. That's what we were doing in my fellowship, but that was now 36 years ago. Make a diagnosis of polymyalgia rheumatica, you sent them for temporal artery biopsy, because we had Scandinavian literature at the time that said 40% of patients with PMR, polymyalgia rheumatica, would have temporal arteritis. That's not American literature. It's probably about 1 in 10. So how do you know when to send them for biopsy? Well, if they're losing their sight, got that call from Lansing General Hospital one night. Doctor, you have a consult, Mr. So-and-so. Okay, that name sounds familiar. What's the problem? Visual loss. I said, yikes, calling a rheumatologist. I do remember him. I said, wait a minute, he's supposed to be on steroids. He had polymyalgia rheumatica. I sort of lost him to follow-up. Well, it seems he had stopped his steroids a few months before. I said, give me a nurse, verbal order, 80 of prednisone statin. I'm coming right in to see him. And a rheumatologist in the hospital at 9:30 at night, what are you kidding? So went in to see him. He was lucky, he saved his sight. But other than the obvious visual loss, what are some of the, and there's the, that's where it gets its name, giant cell or temporal artery. They're the giant cells, multinucleated giant cells. But the real pathology they look for is disruption of this elastic lamina, and this temporal artery has some clot in it. So I don't think I put the slide in, but when do you biopsy? Visual loss? I'll never forget a great case in Michigan too. Nice older gentleman, wouldn't have been me, but he said it hurt when he combed his hair. A guy at 80 years old, a beautiful head of hair. It hurt to put a comb through his hair. It hurt his scalp. Scalp tenderness, you send them for biopsy. It's a sign of temporal arteritis. If they have amaurosis fugax, like the patient in the hospital, the shade coming down over their sight, losing their vision, so visual loss, headaches in the temporal region, and last but not least, a symptom, a clinical symptom that is almost pathognomonic for giant cell arteritis, I put this in the medicine boards years ago. I always say if I ever had this problem, I'd be in trouble. It's aching in the jaw as you talk or chew, jaw claudication. Jaw claudication is found in 50% of temporal arteritis. If they have that, they go for biopsy immediately. In the meantime, while you're waiting for the biopsy results, you bump up the prednisone to 60 milligrams a day, or as they say, 0.7 to 1 milligram kilogram per day. And I keep them on a high dose for 1 month before I start to taper. And we've learned again recently through UpToDate again that 81 milligrams of aspirin will help avert some of the occlusive disease, so you add that. And you're in the audience and say, but Pascucci, adding aspirin or an NSAID to steroids, doesn't that increase ulcerogenic potential? Only by about 8 times as common, even 81 milligrams. So this is medicine. You place your bets, you take your chances. It's the balance between therapeutics and side effects, risk, benefit, but that'll help them to not clot. And again, we'll use Imuran, cytoxan, methotrexate for steroid sparing. I think you know my favorite of that group is methotrexate, a lot less toxic than those. All right, here is the next case. It was always fun to teach the Michigan State students, which I had the opportunity to do for 9 good years of my life. I really enjoyed it out there. And I had this very bright, young, intense female 4th-year student. Oh, she had to know everything about everything. And she was with me 2 weeks, and I said, you know, you've been doing pretty well. You want to see the consults first? And then it only took office hours about 8 times as long, sort of like that steroid and aspirin thing. You see the patient first. You'll present the patient to me and the team. Then we'll go in and see the patient together. Okay. She comes out after 30 minutes or so. Dr. Pascucci, I'm embarrassed. I said, what are you embarrassed about? She says, I have no idea what's wrong with this patient. I said, that's my day in the office every day. I don't know what's wrong. Some of these, what are you talking about? She goes, really, I thought after being with you, I would know something. I said, well, let's have the story. She says, well, this lady had a swollen knee. I said, her age, 72 years of age, presents swollen hot knee 6 months ago. I said, what happened? She went to see her family doctor. What happened? Well, the doc ordered a rheumatology consult. I said, no treatment, no treatment. Okay? So what did the rheumatologist say? Well, she couldn't get an appointment. Some things never change. For 4 weeks. So she was better by the time the appointment, so she didn't go. Is that it? No. 3 months after that, the other knee got hot, swollen, and hurt her. I said, so what did she do? Well, she was consistent. She went to see her family doc. What did he do? And he was at Michigan State at the time. But what did he do? Well, he got a rheumatology consult. No treatment, no treatment. Okay. What happened? 4 weeks later, she's better, didn't keep the appointment. He said, so what happened now? Well, this time her wrist was hurting, and the doc called you. And Pascucci has many theories of life, and one is you better practice what you preach. And if you're not 100% sure that patient doesn't have a septic arthritis in a single joint, you have to see the patient. The only way you're going to know is by seeing them and tapping the joint. So I saw the patient either that day or the next day, and this was the consult. Imagine that. I said, he didn't call me the first 2 times. I must have been lecturing somewhere. But so we happen to have a radiograph. I said to the student, I said, you know, you gave me a great job. You did a great job. You gave me the diagnosis. I have no idea what's wrong. I said, but I do. You took a great history, and that's what we do as doctors. We're listeners. Rheumatology, 88% of the diagnosis is obtained by the history, just like family medicine. That's what the numbers say. Physical adds 7-8%, lab and x-ray, which these young doctors love, maybe 3 or 4%, you know. So I said, and look at your x-ray, it tells the story. She says, what are you talking about? I said, don't you see it? When a patient has acute monarticular intermittent arthritis that remits spontaneously, you know they are in the category of crystal-induced arthritis. It's crystal disease. And in this case, you see the stippled calcification within the fibrocartilage of this patient has, very good. Within the triangular ligament there, I sort of said that like a Philadelphian triangular, I sort of mumble it out, you know, triangular ligament. The radiographic term for any radiologist in the group is lovely. It's a 6-syllable word. You're in bonus land and Scrabble, as I tell the kids. Chondrocalcinosis, the acute syndrome our patient had, is the docs up front hollered, acute pseudogout. The chemical is calcium pyrophosphate dihydrate, and the treatment is non-steroidals, and it goes away. But it's an acute, intermittent, short-lived. There's the more classical joint. The knee is the most common joint involved. That's the x-ray you're not allowed to miss on recert exams. Or, I wonder if your House of Delegates is discussing continuous certification exams. Everybody's having so much fun in medicine. But stippled calcification within the fibrocartilage again, chondrocalcinosis, pseudogout. The knee is the most common joint of this disease. It's usually 60-year-olds and older, hence our lady was 70. And there it is in the wrist, which is the second, I didn't throw you a curveball, the second most common joint involved in pseudogout. And there are the crystals. Certain things we have to memorize in life. It's what I tell the students and residents. Weekly, positively birefringent. When you have it lined up with the red filter, and there you see the nice arrow, it's blue. Turn it perpendicular, it goes to yellow. It's the opposite of gout. This is calcium pyrophosphate dehydrated. It's also rectangular shape 90% of the time. This is acute pseudogout. We don't have any long-term chronic therapy of pseudogout like we do for gout. We don't have an allopurinol. But some patients, they'll say, Doc, I'm going to Europe, and I'm afraid my knee is going to flare. What can you do for me? Dr. H. Ralph Schumacher, one of our esteemed rheumatologists in Philadelphia, he may have retired by now. Docs who train me are retiring. I'm getting that old. But he taught us that colchicine, you can take this one back to your offices. Colchicine, 0.6 milligrams, or Colchris, or Colchris, whatever way you want to say it. It's only 10 times as expensive. I love the FDA too. Colchris, twice a day, will help prevent pseudogout attacks. So if they want to enjoy, and then you always give them the steroid pack to take with them, as long as they're on vacation and want to enjoy it. The Colchris should prevent pseudogout as well, from H. Ralph Schumacher. And there's a disease we can't miss, which is gout. And there's tophaceous gout. And you can understand why sometimes Yeah, I used to tell the students, I didn't know what was wrong with this kid. He came back in 2 weeks, and there you go again. But no, just a little facetious there. But you can see the differential with rheumatoid arthritis sometimes, that house staff gets confused, primary care docs get confused, and I said, I don't understand that. The longer I practice, the more confusing tophaceous gout is for me as opposed to rheumatoid arthritis, because only about 35% of these patients will have rheumatoid factor positive also. But there's one easy formula. That one will be easy. You take that schmutz and that finger there that's weeping, smear it on the slide, and you'll see the crystals of gout, and you know it's gout and not, whoop, I hit the wrong button. And you'll know it's not rheumatoid arthritis, but it's gout when you find the crystals. Okay, moving along. Again, I better step it up. What do you think? A few of us in here are starting to get these bony bumps, Dr. Heberden politely put his name on them, or if you're in England, they call him Dr. Heberden. His nodes, Bouchard's nodes, sparing MCPs, sparing wrists, little step-off sign or shelf sign at the first carpal metacarpal, osteoarthritis, by far the most common, affects about 22 million Americans. You'll see a ton of these patients in practice. Why do they come to you? Pain. We Americans are spoiled. We don't want to have pain, although oftentimes these hands can be asymptomatic. But they'll come to you with other joints that hurt. Drug of choice is one doc told us earlier to be careful about, and I am, but I use it. What's drug of choice for osteoarthritis? Makes a great continuous certification exam question. Acetaminophen, Tylenol. Patients go, what? I drove 50 miles for you to give me Tylenol? And the Federal Drug Administration has come up with a maximum dose per day of 2.6 grams. Where'd they come up with that? As I say, I cruise the aisles of CVS periodically to make sure what my patients are grabbing over the counter. And then I fell upon arthritis formula Tylenol. And I said, what is that? It's marketing is what it is. 650 milligrams rather than extra strength Tylenol. They take 2 of them twice a day. You do the math with me, 2.6 grams. So the initial studies from Kenneth Brandt at Indiana University for Tylenol and OA, first of all, compared Tylenol to Motrin, which some of us feel is not the most potent anti-inflammatory out there, but they did. And that's when it became our drug of choice, 1993. His dose was 3 grams a day. So now we're backed off to about 2.6 grams. Worry about liver disease, you heard. And may interfere rarely with warfarin, which so many of our older patients are on for atrial fibrillation. So just watch the INR. Some symptoms I'm going to skip through because I always like this slides. Joints spared in osteo, MCPs, wrists, shoulders, elbows, ankles. Those joints up there, well, MCPs are not involved. That's how you differentiate it from elderly onset RA. Wrists, shoulders, elbows, and ankles are not weight-bearing joints. So it shouldn't involve those. It involves DIPs, PIPs, first carpal metacarpal, low back, hips and knees, which are weight-bearing, and the big toe, the first MTP. The ankle, biomechanically, is not a weight-bearing joint. So, I get to teach not only the docs, but the PAs at PCOM, and one of the PAs said, Dr. Pascucci, yesterday in class you told us that the drug of choice for osteoarthritis is acetaminophen, Tylenol. I said, yes. Harrison states, I said, oh, you're quoting Harrison's, I'm proud of you. Harrison states that NSAIDs are the most widely used drugs for osteoarthritis. I said, okay. Drug of choice, acetaminophen most widely used, NSAIDs. They're 2 separate statements. I said, and yes, not everybody's going to respond to Tylenol, so we use NSAIDs. And I'm going to get into a little bit of that, so I'm going to pick it up with osteoarthritis. Medical management, there it says it in print, oral, acetaminophen, or topical. I'm not a fan of opioids, sorry. Rheumatologists are a weird lot. There are some of us who are very aggressive. Nobody should have pain. They give out opioids. Those of us who are extremely, extremely conservative and say, well, my patient's going to have pain for a long time. I'm going to find other ways to treat it. I'm not a big fan of opioids, although I will use a little bit of tramadol. And this will be in your outlines. And we do have our ACR recommendations for medical management of OA and hip and knee, and we expand that to others. I'm also not a big fan of the topicals. Our geriatrics department at PCOM uses a lot of topicals, Voltaren gel, this one, lidocaine. They're nice and all, and they help, but these are patients on fixed income. And a lot of times the co-pays on those fancy drugs are astronomical. And if they ask me, same thing for chondroitin, glucosamine, I don't recommend it because insurance doesn't cover it. $60 a month for a patient on a fixed income. I say, if they ask me about it, I tell them, mild to modest effect on osteoarthritis of the knees. I have rheumatoids coming in. Doc, I'm taking glucosamine. Do you think it's helped you? No. I said it shouldn't because there's never been proven. So I'm not a big one for using glucosamine chondroitin either, but this is personal opinion. I do some Synvisc, Orthovisc, hyaluronic acid injections of the knees. It helps about 70% of patients for 6 months. Okay, for $500, $700, okay, it's costly. My problem is using viscosupplementation is not yet proven that it keeps people from the operating room. Future directions, you think with 22 million Americans, probably closer to 24 having osteoarthritis, 24 million out of the 60 million Americans with arthritis, 1 in 6, I'm sorry, 50 million Americans, 1 in 6, 50 million. You'd think we come up with a disease-modifying intervention. We told you that methotrexate, DMARD of choice, disease-modifying antibiotic drug of choice for rheumatoid, no such animal, nothing that stops the disease process in osteoarthritis. So that's where we have to go, and I'm a rheumatologist, and I'm going to tell you that there's still the major breakthrough in the management of arthritis in the last 50 years in this country is the total joint replacement. My surgical brethren doing it. It's helped give people their lives back. I find, again, my urban population very nervous about having somebody, as they would tell me, cut on them. And I say, you know, there's only so much this rheumatologist can do with Tylenol, NSAIDs, steroid injections, which I still do in joint. Viscosupplementation, I sort of skip through steroid injections. This is sort of a red herring. Anybody know what this guy has, if you've seen it? Looks like psoriasis, but yet it looks annular there. Worse than the sun. There's his daughter. He's got lupus. And you say, lupus? Come on, that's young people. Well, there's late onset lupus. Just touch on it briefly. Occurrence after age 50. Females still greater than males, but not quite 9 to 1. And we don't think about it. So my job here is to have you think about it. They will have pleuropericarditis, some nephritis, not as bad, and there's a nice x-ray of the water bottle heart or pericardial fusion and pleural fusion of a lupus. The criteria will help you. They won't get as much Raynaud's, neuropsychiatric disease, alopecia, or lymphadenopathy. And then drug-induced lupus is one you will see. And there's a ton of medications. I thought I corrected these slides. Oh, but I sent them earlier, and then I found corrections. It's corrected on my thumb drive, but not here. What are the systems spared in drug-induced lupus? And this is more common in Caucasians than African Americans. Regular systemic lupus is twice as common in African Americans. And there's a whole host of drugs which cause it. How do you make the diagnosis? They're on a drug that's been known to cause drug-induced lupus. For at least a month, they develop symptoms compatible in a positive ANA. What is the antibody that tends to go along with drug-induced lupus? It's not specific. Very few of them are. But we love to ask that for exams too. And here's the list of drugs. The list of drugs, I used to say the list of drugs that won't cause a positive ANA is shorter than the list of drugs that do cause a positive ANA. Antithyroids, psychotropics, oral contraceptives. It's somewhat debatable in our literature, but the question mark is not there. And I've seen a number of young ladies over the years who take the pill and have developed drug-induced lupus. The antihistone antibody is the one that is often seen in drug lupus. Osteoporosis, I think I just want to touch on, I have about 7 minutes, so a couple new meds, teriparatide. Have you used some of that? Alias Forteo. It's a tough sell to a patient that they have to take a shot a day for a disease they don't know is there. You know, the silent epidemic, osteoporosis. But I use it when they fracture or if their DEXA is just horrific. Try to prevent fracture. It's an anabolic type drug, so it builds bone rather than inhibiting the osteoclast, which so many of our drugs do, including the bisphosphonates and all. And I've used it on a few patients. The DEXA material you get is unbelievable how well it builds bone, but it's not for everyone, and it's pretty costly. This says wholesale price is $75 $7,600 a year, so you know what the price of the patient's going to be, probably almost twice that. So you're spending a lot of money for a daily injection. Now, if they feel the fractures, that's one thing. And some of Optimum Living, the data on, oh no, I think that was a different paper I read, not that. The data on hip fractures in patients over 80. The latest data I said, one-fifth of them won't be alive in a year. I should say 33%, so maybe we're getting better, but about one-fifth of them won't be alive in a year, and we're trying to prevent fractures of the hip. Sometimes people said, well, this parathyroid hormone with bisphosphonate may work well, call it Fosamax. Well, no synergistic effect. Matter of fact, it may have offset the effect. Although raloxifene, I think it's one of the most underused drugs in the country, Evista. Docs are scared to death of any estrogen-like product. It's a SERM. Matter of fact, the STAR trial showed us that it may reduce the incidence of breast cancer, and certainly may reduce the incidence of recurrence of breast cancer in patients who have it. But docs just say, ooh, if anything went wrong and I gave them an estrogen-like drug, yikes. It's probably why I just read on the way out here on the plane in my New England Journal of a week ago, 2 weeks ago, that Paxil was recently, paroxetine, approved, FDA approved. They overruled their advisory committee, FDA approved for treatment of hot flashes. Have you been using it in clinical practice? Yeah. I learn something every day. It's the fun of medicine, you know. Another new drug out there, I do like this one too. I guess you sort of learn my likes and dislikes. Denosumab, alias, I always told my patients it's Prolia until the actress whose name I can never remember on TV refers to it as Prolia, I call it. It's a sub-Q injection, twice a year. I don't know why, but they'd say it should be administered in the doc's office, so I do it, and you can do it, and you can bill for it. The patient, I prescribe it for them, they bring it in and we inject it, you get an injection fee. But the way it builds bone compared to the age-old Fosamax, our first bisphosphonate, I've had really good success with patients who have severe osteoporosis and this drug, and they haven't really responded well to bisphosphonates are first. They're reasonably priced, they're very effective. What are the two, and that's how that drug works, what are the two side effects you have to worry about with the bisphosphonates? Good, GERD, very common. And the other is musculoskeletal pains, but now we're going to talk about serious, and I clipped ahead, the serious ones that everybody worries about, osteonecrosis of the jaw, ONJ. Rare. I'm not going to be able to go through all the slides, but you'll have it in your outline. It's almost always seen in patients with an underlying cancer who have been given an IV bisphosphonate, like Zometa, and who have gotten more than one dose and had a recent extraction or something. But, you know, the dentist in Philadelphia, patient needs a tooth extracted, they're on, I won't touch it until they're off Fosamax for 6 months. I said, stays in their body for 10 years. You're treating yourself there, but I mean, come on, you know, but I'll do whatever you want, doc, whatever you say, you know. But there it is, 85% had multiple myeloma or breast cancer, so that's one you have to be aware of, how it presents clinically. Treatment is difficult. Nobody has a great answer, and there's the treatment. And the other one is the diaphyseal fractures of the femur, subtrochanteric, and I'm going to get to the editorial. Occurrence of atypical fracture was rare, even among patients treated for 10 years, no significant increase in risk. Here's the editorial from Elizabeth Shane from Columbia in the New England Journal of Medicine, again, 2010. Let me get to her summary, because I'm running out of time and I will not go. What are the implications of the Black et al. Study for clinical practice? Subtrochanteric fractures are extremely rare. Many more devastating hip fractures are prevented by bisphosphonates than caused by them. Give that 3 stars. That's the important point. Detailed recommendations beyond the scope of this editorial. Consider drug holiday. Here's where my college of rheumatology won't take a stand. We rheumatologists could be radiologists in our next life. We hedge a little bit too. And some doc, I heard an endocrinologist speak at our state convention 2 weeks ago. I give my patients a drug holiday, was what he said. I do not. And I like the data that said use of alendronate, which is the culprit orally, if there's going to be one for these hip fractures, for 10 years compared to 5 years was associated with significantly fewer vertebral and non-vertebral fractures. So what they're telling you is patients are more likely to fracture if they're not on the med than if you give it. And I didn't talk about the fracs. Are you getting a fracs when you do your DEXA scans now? The fracture reduction index. Some of the hospitals are doing it. University of Penn in Philadelphia will give you their fracs, whether it's 3%, 10%, whatever. Do they need treatment? We're trying to find a better way than the old DEXA scan as to predict who's going to fracture so we can be more aggressive in treatment. Strontium granulate reared its head again. I found out about this early 2000. It's not FDA approved in the States, but it's getting some noise in the literature again, relaunched, blah, blah, blah. It's not FDA approved, and for severe cases, I've sent a couple patients at least for vertebroplasty when they fracture, and they get the cement. And there's a fancy slide showing you how to use all these things. Well, I wanted to talk about NSAIDs in the elderly, and it's a hot topic. And we all know that the latest data, this says 111 million prescriptions. Well, I guess docs are getting a little more nervous. 60 million was up-to-date statistic for the year 2013. 60 million scripts in the United States, a $10 billion a year market. We're talking about geriatrics here. Here's some of your uses of NSAIDs. Should we use these drugs at all? Not just COX-2s, but should we use them at all in our geriatric population? The Beers criteria for potentially inappropriate medications. NSAIDs are all over that sheet. Avoid in the elderly. I don't think I can practice rheumatology without them, but it takes a little common sense. Why do we think, and what's the concern? That NSAIDs traditional NSAIDs may increase heart attack and stroke. We all heard about COX-2 inhibitors, right? Vioxx, boom, history. And I did see a lot of swelling and hypertension from Vioxx, but I didn't see any heart attacks. I didn't see any strokes, thank goodness. Valdecoxib, Bextra. Did you like writing for Bextra? You know, every once in a while, a non-steroidal comes along that works where many others before it fail. And Bextra was one of those. I was so disappointed when that drug went off the market. But they were giving it to patients post-coronary bypass, and some were re-infarcting. They blamed Bextra. Or more severe rashes, exfoliative derm and things like that. So they stopped. But Celebrex is still out there. But I'll give you my, again, personal viewpoint, and I think a lot of the literature would agree with me. I would not use COX-2 inhibitors in patients who have had an MI or stroke. It could be problems for you if anything would happen. Wouldn't use them. So how about traditional NSAIDs? And what's the thinking behind that? Well, let me get to that. I always hold on to this paper hoping that my 81 milligrams of aspirin a day will help me from getting Alzheimer's. You know, it's an old paper from '96 showing NSAIDs, a positive protective effect on cognitive decline. It's not, they can't put that on the label, it's not FDA. But it was an interesting paper, just like I do crossword puzzles, I drive different ways to work, I drink a couple drinks of red wine a night. That's the only reason why I don't want to, it's the only reason. COX-2 specificity. Here's the hypothesis. How do they get vascular? One of the most potent, if not the most potent, vasodilator in our bodies is prostacyclin. And if you inhibit prostacyclin with a traditional NSAID or a COX-2 inhibitor, we used to feel that perhaps if you used a traditional NSAID, you had that inhibition of platelet aggregation, stickiness, inhibition of the platelet. So that would offshoot inhibition of prostacyclin and maybe protect the patient. That's why we didn't hear much about this until along came the COX-2s. But the COX-2s have no effect on the platelet. Hence, they're a little safer. Hence, they're less the cause of GI bleed. And they do inhibit prostacyclin. So you've lost the compensatory mechanism, perhaps. Just a theory with why COX-2s can get you in trouble. So don't use those. And there's some of the trials where drugs went off the market and some of the, will I use traditional NSAIDs in my geriatric population? Yes. Will I, is there anyone that might be a little more safe, a little safer, better English. There's that same slide. I wanted to get to this too. Inhibition of clinical benefits of aspirin. Well, it all has to do with platelet inhibition. And we used to always say, I remember giving a lecture in a nice exotic area at a CME course years ago, and a good busy internist said, well, Rich, if my patient's on Voltaren, diclofenac, every day, that inhibits the platelet. That works. I don't have to give them aspirin if they have heart disease, right? I said, wrong. 2 reasons. Aspirin's the only drug that inhibits the platelet for the life of the platelet, 10 days or so. Number 1. Number 2, Voltaren, half-life about 12 hours. If they miss a dose, they're going like this with platelet inhibition. And you can't guarantee they'll take it every day, and even if they do, you can't guarantee it'll inhibit the platelets. So you keep them on their aspirin, even though aspirin plus an NSAID is not a great combination for the gut either. So let me get to the million. Do I use them in my geriatric? Yes, but it's me, one speaker. You make your own judgments again. If I had to choose, and I had a very educated patient come in the other day, now, Dr. Richard, you know, I've had my stent, right? I said, yeah, I know what he's getting at, because he's got gout, he's on diclofenac and he's got OA at the back, diclofenac. And he says, I've read about, look, here's the package insert. And it is in the black box for all of them. It's even in the black box on Voltaren gel, because you do absorb some of that these drugs can rarely cause heart attack and stroke. He says, so what do you think? I said, well, our literature shows that if there's one best non-steroidal anti-inflammatory drug for inhibiting the platelet, preventing heart attack, preventing stroke, it is naproxen. So if I have to use it, I go, and it's the most widely used in the United States, by the way. So I use naproxen, but is it 100% end-all be-all? No. And this is the business about inhibition of clinical effects of aspirin. There was some talk on Motrin. Whoops, time is about up. And that's debatable, but it's probably not the best, and I think the best thing we could tell you is take your aspirin 2 hours prior to taking the NSAID. If your patient's taking their 81 milligrams of aspirin and taking their Motrin, naproxen, Voltaren for their arthritis, and they're not at risk for heart disease or stroke. And if you think this is news, that's why this one didn't scan very well. Sorry, a little fuzzy. New England Journal of Medicine, 1981, coronary vasoconstrictor effect of indomethacin in patients with coronary artery disease. Big article in the New England Journal, and some busy, outspoken rheumatologist, he wrote a scathing editorial denouncing that paper, and the whole thing died off with just one big shot writing an editorial. So you say, how about that? It's been around our literature now for 33 years about is there an effect of NSAIDs and causing heart attacks and strokes. So you take your money, you bet your money, you take your chances, risk benefits, you make the decision, you talk it over with your patient. And I always write in that chart, I always type in my electronic health record, risks and benefits of this medication, discuss at length with the patient, period. They were warned of the risks. And if I leave you with one slide, when we use long-term, that was one important point too, and then Dr. Whiting made that point too. Do not use NSAIDs in high-risk patients for any longer and for any higher dose than you absolutely must. And if you can get them out of it, get them off of it. And I find with osteo, sometimes you can break up the pain and get them off the NSAID. You're not quite as lucky if it's an inflammatory disease, although I'll tell you, with biologics, TNF-alpha and other drugs, I can taper the methotrexate, taper the NSAIDs, and just keep them on the biologic agent. But make sure you monitor patients on long-term at least 4 times a year, as long as, if I start a new NSAID in a high-risk patient for kidney disease, for liver disease, I monitor the lab 3 weeks later. If it's good, then I do it a month after that. If it's good, then I do it every 3 months. So monitor according to Cork. I'll stop there. I'll take 1 or 2 quick questions, unless you want to go have dinner. Yes. No pain relief from Tylenol? The question was, is there any biochemistry reason why people get no pain relief from Tylenol? No.
It's just simply an analgesic. We tried to preach there. Boy, my voice gave out just in time. We tried to preach that Tylenol had some anti-inflammatory effect, but it has none. And I think that NSAIDs work better for pain syndromes because there is some amount, small, microscopic amount of inflammation with the pain of osteoarthritis and others, and that's what you're really treating. So, yes? I can't quite hear you, I'm sorry. MRI? Oh. The question was, can an MRI or MRA take the place of a temporal artery biopsy? The easy answer is no. MRAs are pretty good, but again, it depends on the examiner. And actually, you can say, well, my community hospital, they might see 2 temporal artery biopsies a year. How good are they at reading it? Still part of the problem, but we like to get tissue before we put people on high-dose steroids and Cytoxan, if at all possible. And I'm just concerned they don't see enough of it to be able to read the MRI. Good question. Well, I should let you folks get off to your meetings and dinner, and nice to see you all again. Nice to be back in Michigan.